in about 5 seconds. Is that okay for you?
Good for me, yeah.
Okay.
Steve Cooksley, sorry.
Yeah, sorry, Steve Cooksley.
I apologise there.
Yeah, you're in charge of the tech now, Steve Dilworth.
Yeah.
Okay, Steve Cooksley, we're going to make a start. Big welcome to everyone to the 59th meeting of the Council of Governors, to be held online again because of the COVID outbreak. A big welcome to everybody, but a very big turnout today. Particular welcome to a whole lot of new governors. We have Janice Algar, Les Clark, Michael Earnshaw, Ravimba Mutiambizi, Ray Warburton, and Stacey Washington. We have apologies from new governors from Margaret Adeji and Sid Deshmukh. So a really big welcome to our new governors. Thank you so much for coming forward to stand as governors to help us through what's going to be, without doubt, an exceptionally challenging time, not only internally, but externally. Just a few housekeeping points before we start. Usual rules apply, please, if we can stay on mute when we're not talking. I'm very happy, as we all are, for interruptions at any stage. So put your hands up if you want to speak, and if I miss your hand, then Sally will help me out and let me know that you've got your hand up, because clearly we have a full house and getting everyone on the screen is rather difficult on that point. Just from my end, just again, a few housekeeping bits. I'm still recovering from an operation. Every now and again, I have to get up and walk around. So I shall switch my my camera off while I do that, so I don't disturb you, just while I do my brief exercises, so I can stay with it for the duration of the meeting. And we'll have some breaks so that we can get a cup of tea or whatever in between the various items. So again, big welcome to everyone. So we'll make a start. If there are, I've mentioned 2 apologies for absence. Joe, are there any other apologies at all? Joe Mant, any other apologies?
Fine, I'm mute.
You're off mute.
Right. Sorry, Andy, technical blip. We've got apologies from Margaret Adeji, Sid Deshmukh, Mark Ellison, Joe Lain, Cara Lee, and Miranda Williams and Joe Stevenson. Okay, thanks very much for that. We've got the minutes of the last meeting. There are a lot of minutes there. I would hope that anyone's raised any substantive points beforehand, but it doesn't stop you raising them now. But we'll go in through page by page, and if people they'll have to sing out, to be honest, because it's hard to read these out and to look at the screen at the same time. But on page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and 16. Are there any other matters arising from there? I can't see anything from anyone. Doesn't stop you raising later on if there's something that crops up. And if not, we'll move straight on to the update from Matthew, please. Thank you, Matthew.
Thank you, Andy. Can people give me a thumbs up if I'm coming through okay on the sound? Yeah, it's smashing. Thanks very much. Good morning, everyone, and welcome to, I think this is the last sort of formal set piece for Oxleas in 2020, and it's been quite a year, I think, a year unlike anything any of us will have experienced before, and hopefully ever will again. So I'll talk a bit about a couple of things that are in my report and just add 1 or 2 more bits of information for you. So COVID has been dominant, hasn't it, throughout this year in terms of some of the operational challenges we've had to deal with. And we have seen over the last couple of months an increase in the number of cases, although that's now tailing off in line with the general profile that we're seeing of COVID in the patient population, the inpatient population within London. The number of cases we've had in this second wave has been below earlier this year, as has the vacancy rate, but we are being very careful to keep an eye on this and manage it. We have the dynamic that lots of our staff live in Kent and work in South East London, and I know Bexley as a borough in particular has had challenges in terms of people coming across from Kent into London and bringing cases in with them. So we've been very careful to try to manage that. And when we have had outbreaks in amongst our teams, we've been very quick to try to manage them and reduce them. Staff now have twice weekly testing available at home, and these are fairly immediate tests where you get the results within around 30 minutes in your own home. So that's great in terms of people understanding whether where they've been at risk, or they want to check their own health, or they get the worries. I've not spent a year in my life where I've spent so much time trying to smell coffee in the morning to make sure my senses are still functioning properly. But we've now given staff that confidence that they can test themselves and see whether they're safe, whether they've been in those environments, and whether there's that risk of taking it home. So that testing's been really vital in this second wave. It's not perfect, is it? But it's much better than what we had before, and it is picking up cases we'd otherwise have missed. And also the vaccinations have now started in South East London, and it's been great to see 3 South East London sites this week begin vaccinating the most vulnerable groups within South East London. And as the Oxford vaccine comes on board, that should be licensed in a couple of weeks' time. That will offer us the ability to be much more flexible about offering it in community settings and through general practice as well, because you'll have read this about the Pfizer vaccine needing storage in a very cold set of freezers that aren't commonly available. So we'll see that wider rollout. And what all this means is that between better testing and access to protective vaccines, we can see a way in which COVID can become a manageable disease, and in the same way that we live with conditions like measles and flu and polio and all kinds of things that at various times in our lives have been very dangerous and very high risk for certain patient populations. Actually, we can see a way through this. So I think we end 2020 on a note of real optimism there, but it is cautious optimism. And for our staff, for the next 3-4 months, and for people working in local authorities and working in our partners, places like Charlton and the Bridge and Hestia and other organisations we're working with, we really need to make sure that we all keep our focus on that basic message of hands, face, space. But we end the year stronger than at times it seemed we might do, and there's a lot of good we can take from that. And thanks very much to all of our partners and to our staff who've really, as have all of us, been through it this year, and I think coming out of it though with a way through it in sight. So we can look forward to the spring, and it's been great to see the partnership. Thank you very much to Debbie Wedden in our workforce team, who's been working with London South East colleges to offer a variety of roles available to support the vaccine rollout. This is not just for clinical staff, it's also for admin support and customer services. And working with our partners in London South East colleges, we'll be training local people in these new roles and bringing them out into jobs. These aren't voluntary roles, these are proper paid roles through the vaccination scheme as we work our way into the spring. So it's great to see us partnering with a local partner in the colleges to really try to create employment opportunities as we come out the back end of this second wave of COVID. We presented about building a fairer Oxleas in September. The other really significant moment this year, I think, has been the attention on inequity and inequality that was first raised through the Black Lives Matter movement earlier this year, and has led us to have a really good hard look about the values and behaviours we display as a trust. It's given many of our staff the opportunity to talk about things that they've lived with for years, decades in some cases, in the NHS, and how they've experienced unfair outcomes, unfair lack of opportunity in work, and we're working hard to try to address that. And we've just launched a new shadow executive team, which is made up of a dozen people who are in the trust, who are relatively new to the NHS or have relatively recently finished training, and they're going to be looking at all the same papers and contributing to the decisions we make. And this is to try to promote new opportunity, new leadership. We've been doing some specific work on cultural issues, and this is some of the stuff that I think a lot of us struggle with. How do you talk about race, or how do you talk about difference, experience of mental illness, sexuality, gender, these kinds of things in the workplace, and really trying to make us an organisation that creates the opportunity to reflect the strength that we get from recognising difference and celebrating it at work, and also recognising where some of us need to change our behaviours and the way that we engage with people to create a fairer and more equal place to work. And we've had a real good look at our recruitment and progression policies around that, and you'll keep hearing about building a fairer Oxleas, because I think actually, COVID has been a relatively straightforward healthcare disaster in some ways, in that it's a pandemic that's behaved exactly as all the modelling tells us a pandemic would, and we've had to get to grips with it. And the NHS and local authorities and others have done an incredibly good job, I think, locally, of trying to manage this in some tough circumstances. But you know, you're a healthcare service, you have a pandemic, you kind of know what to do, and I think Oxleas has approached that well. This stuff around deeper cultural inequity is actually a much more profoundly complicated and challenging issue for us. And I think over the years ahead, actually, the change we see in the way the health service works in response to this could be more significant than the changes that we see wrought by COVID. And that's no bad thing, because as we've seen through COVID, inequality ultimately can kill people, because if you suffer from that kind of inequality, it damages your health, and the profound implications, these are ones that will be with us for a long time. And there's a brief bit in my update about strategy development. I mean, I'm not going to say anything more than that, other than we'll return to that in the new year when we've got the time and the headspace to think about these really important elements of our strategy. Just to say that we are seeing, we're really working our way into our waiting lists that increased during the pandemic to try to get that down. And I've had a couple of conversations with carers groups and with patients recently about the impact of delays. We really do need to keep these foremost in our mind as we think about what 2021 brings. And also great out of hospital care. We're seeing some really exciting developments in improving the quality of our hospital offer, to make sure that if you're an inpatient, it's a really purposeful admission. If you're supported in the community, whether it's by our physical or mental health care teams, we really want to see what we can do to improve the quality of that, improve access to it, and also to try to do away with some of the slightly bureaucratic barriers that get in the place of people accessing that care when they start to need it, rather than waiting until they're particularly unwell and then coming in when it's a bit too late to have the best possible impact. And CQC have continued to inspect and to look at complaints. And I saw Ted Baker, their Chief Inspector of Hospitals, put a blog out yesterday saying they've had a huge increase in correspondence from patients and staff across the whole NHS this year because of the kind of issues that we've been facing. And we had inspections of our mental health teams in Eltham, where they've published those reports. They've identified some areas for improvement. I mean, I was talking to Rachel Matheson, who looks after Eltham for us yesterday. We've got a great team in there now with Laura, the service lead. And it's one of the services where we get some of our very best patient feedback, and it's really interesting to contrast the need for our teams to keep that focus on the quality of care we deliver alongside making sure we get the technical aspect right. And we've had a disappointing inspection report back from some of our older adults wards. These are wards that have dealt with some of the real brunt of the pandemic this year. It's where we've seen, our most vulnerable patients exposed to COVID in the first wave, and the staff there have worked tremendously hard to make sure that good quality care has been maintained there, and they've looked after the service users and their families there. CQC came in to have a specific look at ligature risk in there. So that's points within the wards where there's a risk that a patient may cause themselves significant harm as a result of it. It's always been a factor in older adults wards that we've had to look at physical safety around falls risks and slipping and tripping, and make sure the environment's catered for that. But after a couple of serious incidents last year, and we hadn't had any for 10 years before that, CQC came in and had a really good look at ligature risks only at that, and they've been clear about that. It was focused on this and not looking at the wider quality care. But they have told us that we require urgent action to put some of these ligature risk challenges right. So we are likely to get a warning notice published on that in the next couple of weeks. And what that means is we've got to act immediately to avoid the risk of any further action. We asked CQC in the feedback session who we could look to for good practice on this, and they said it's a hard thing. They couldn't point us towards anyone else to find good practice examples, but we did find that the last sort of NHS improvement good practice publication on ligature risk was an Oxleas case study in our older adults wards. So we need to learn from ourselves, learn from the good practice that we introduced in Oxleas older working age adult wards, and really turn that around in the older adults. And I know the teams have taken it as a bit of a blow after a year where they've really focused on looking after the people in their care, but we will bounce back strongly from that. Christine Kapopo, our Associate Director of Nursing, is leading a ligature risk good practice group, and I'm confident that we'll come through that strongly. And I think it's worth noting that 2 of our older adults wards actually won team awards in the recognition awards this year, in recognition of the huge amount of work they've done with patients and their families through a really, really tough year. So I want them to bear that in mind. And as Chief Executive of the Trust, I'm confident that we'll mount the right response to that. But, it's not to downplay the fact that, ligature risks in wards are a really important thing. They're not an easy thing to manage. There'll always be a a risk factor there, and it's about how we manage it day to day. But you'll see that warning notice. We'll make sure we share it with people, and we'll make sure that when we speak to you next in the new year, that we tell you about what we've done to put that right. So I think that's probably everything in my immediate update that I wanted to talk about today. There's a bit in there also about some proposals that have come out from the national team around development of the integrated care system. These are starting to take shape. They're focused around partnerships in South East London. You'll remember probably the STP. That's now become the ICS, the Integrated Care System, and that's the partnership of NHS trusts, general practice and local authority partners in South East London, working together to look at how we can best provide joined up care. Providers like Oxleas are being asked to come forward in more formal collaborative arrangements to allow us to work on that scale. We're already in provider collaboratives across South London for mental health, so we're quite familiar with this ways of working. And you'll hear more later today from Stephen Dilworth and I about partnership working. As this takes shape over the course of next year, we'll let you know what this means for us as a foundation trust and working with our partners. There's a consultation open, and South East London will be writing a letter back to that consultation with some of our views. So we'll very much make sure that we share that through Richard with the governors as we come to our views on that. I think it's a good opportunity to look particularly at how we're working with primary care. And I think the tension in there is going to be how we work across South East London, as well as having those real conversations in the local place, in Bromley, in Bexley, and in Greenwich, and how we make sure we don't lose sight of those local relationships, which are such an important part of what we do. And when we're also part of these South East London collaboratives, I'm pretty confident that we are a trust that leads in terms of partnership working. There's 10 provider collaboratives in the country at the minute, and Oxleas is part of 3 of them. So we're very much at the forefront of this kind of thinking, and actually other trusts are asking us, how do we do it? And I think we're in a good place for that. So 2020, I think, for a lot of us, we'll look back on this personally and professionally as one of the hardest years we've experienced. It's a year though where, I joined IFE and the consultants yesterday for our medical advisory committee, and you look around at the people that we've worked with this year and talking to the team, it's a group of people that I'm really proud to be part of. A number of us got together at High Point House up on the hill at Memorial last night. Our music therapists, we've got the biggest and I think the best music therapy service in the UK at Oxleas, really tremendous service, and the Oxleas choir, and we all got together, and it was the first time since March that I think this group of people had come together to sing and play, and we had to do it outside because of COVID. We got it all checked out, so we were all stood outside freezing, and trying to play the guitar when it's 2 degrees centigrade is not much fun. But you'll be able to see that next week on Oxwide. But it was lovely just to be around friends and colleagues again, and to reflect on what this year has been like. And just to recognise that in these sorts of times, you realise where you draw strength, and so much of it comes from the people that you work with and the people that you turn to when you're finding things tough. And I couldn't have asked for a better group of people to work with this year. We've hit the road bumps that you expect to hit in these kinds of circumstances, but I think we've learned a lot, and we've come through it and changed, I think, but stronger for lots of what we've experienced. So thank you very much to the governors for their ongoing support, and that's the end of my update, looking back on quite a momentous 2020. Thank you.
Now, thank you very much indeed, Matthew, and thank you to you and your team and all of the staff at Oxleas for everything you've been doing and are going to do during this extraordinary time. So we're very grateful. Thanks for your update. On the CQC report on ligatures, I've asked Suzanne Shale, non-exec director, to help the executive look at how we deal with serious incidents and the recommendations from those serious incidents, to make sure that we have a really good process for following through and ensuring that the things that are recommended actually happen. This is an extremely complex area, but quite clearly that the CQC have raised some serious concerns to which we must respond. So Suzanne will be leading it from the non-execs on that one. And thank you for the update on the ICS. And I think one of the things that we might have to consider as this unfolds is perhaps even a separate briefing at some stage or other for the Council of Governors, because I know there's a great deal of agitation across trusts across the country about what might happen with the proposed legislation and the role of governors, the role of the patient voice, the role of the staff voice, and anything that might happen in that new So that the Council of Governors are fully apprised of developments and are consulted on development, so that when we're putting our views back to the centre, that the Council of Governors' views are fully taken into account. I think, Richard, you've got your hand up, please.
Thanks, Andy. Matthew, thanks for a very comprehensive report, and appreciate that you and also colleagues in the wider NHS have been rather busy in recent months, but you have told us a couple of times over the past 6 months or so about some very exciting ideas you've had for sort of further developments at the Queen Mary's site in Sidcup, which will bring additional diagnostic facilities there to enable those who live in the area in Bexley, in North Bromley, to go there for when they need tests rather than have to travel into central London or further afield. And I'm wondering if there's any update on how those discussions have been going.
Yes, that's. I mean, this is Richard. I think one of the things where it's been something I've been really keen on for the last since I joined Oxleas, actually, to do some more at Queen Mary's, because I just think it's a wonderful site. And I think, you know, when we take people around it who have not seen it before, they just can't believe what a great resource we've managed to create there with this partnership of providers working together in Sidcup. And as you come down the drive, people will know it who've been to the site. There's the old maternity block on the right hand side, block A, and we're just in the process of demolishing that, and that gives us a brownfield opportunity to build some new NHS estate in South East London without us having to worry about moving services back and forward as we do the rebuild. You know, which is usually the problem that you face with the NHS. You know, you want to do something to change with one building, you've suddenly got to find somewhere for 10,000 patients a month to go for the 2 years it's going to take you to build it. So we've got this wonderful golden opportunity there. And what we've been looking at, Professor Sir Mike Richards published a report looking at diagnostics a few months ago. And in this, he suggested that we should create community diagnostic hubs, which are places where you bring together a lot of diagnostic types. So things like scanner, you know, the kind of MRI scans, X-rays, endoscopies, you know, lots of the stuff that lots of us are used to going into places like the PRU and QE for. But rather than doing it in an acute hospital, to do it in a specific sort of diagnostic super site where you go in and you get all those diagnostics done. And there's already some great examples in London. Some of these are things Mike Richards set up around, for example, breast cancer, where if you go into one of the breast cancer super units, you're in there and you get all the diagnostics done, and you get to see the right nurses and you get to see the consultant in the space of 6 or 8 hours. You get the whole diagnostic pathway done, and you get your diagnosis and your outcome. And these really sort of first class one-stop cancer shops. And speaking to James Brokenshire, the local MP, and to the leader of the council, and to Richard and others, I think there's real enthusiasm for us trying to do something like this at Queen Mary's. And we've now set up a board that I'm chairing, where we've brought together King's, Guy's, Lewisham and Greenwich Trust as the 3 large acute providers. We've appointed a programme manager, and Rachel Evans, our Director of Estates and Facilities, is helping us as a sort of programme director for this, to look at what activity we could put on the site there and what it would then take to build this site there, and to bring services from Guy's, King's and Lewisham and Greenwich together potentially on this site to support diagnostic pathways in South London. Because what we're seeing is every year demand for diagnostics is increasing as we get better at detecting certain cancers earlier. You know, there's more requirement for diagnostics and the waiting lists are getting longer and longer. So what this is about doing is about it providing us with significant extra capacity in Sidcup. And of course, lots of our residents in outer South East London at the minute, you have to travel up to Guy's and King's as well for some of your diagnostics, which isn't always ideal at all. So there's real enthusiasm for this. I had a session a week or 2 ago with the Cancer Network, the Respiratory Network, Neurology Network for South East London, and various others, all of whom basically looked at this and said we could do with some space there. You know, where we currently run services, they're too busy and they're too cramped. The conditions aren't perfect. You know, we would like to look at whether there's potential to put more resource there. And of course, because Guy's have got their wonderful cancer centre there, King's already have dental and ophthalmology there, and actually Darrant Valley were a big important part of this because they serve and support a lot of the Bexley population too. There's really enthusiasm for that, Richard. And I think what started as a bit of a twinkle in the eye 2 years ago is now at the stage where I'm hoping that within a month or 2 we'll have some hard numbers on the table, and we can then start talking to the ICS and to government about what it might look like to get funding for this, because we'd be talking I mean, I think the last development of QMS was a £50 million development for the main block. I think this would be looking larger than that in terms of the capital required to get it off the ground. But I think for people living in South East London, fantastic development. For Bexley, a brilliant development to bring into the borough. Great for QMS, and also great for Oxleas to continue in this tradition of partnership working. So thanks for mentioning that, Richard, and also thanks to you personally for your support and advice as we've started the conversations going on this.
Thanks very much, Matthew. And any other questions there for Matthew before we move on to the operational report? If not, we'll go on. Sorry, Sally, you're saying something?
A chat from Steve Pleasance.
This is about ligature issues. Yeah. So, I mean, Steve, its ligature points have been raised at most CQC inspections of any inpatient setting. They always have a look at ligature risks in mental health settings, and I think we've managed to address the previous concerns they've raised in Green Parks and Oxleas House. But they always do come back, because it's both about the physical environment and also how the clinical staff manage it. But what I suggest we do is maybe do a short briefing note for governors on the current status of ligature risk in inpatient settings, and maybe we can give you a bit of information about the working group that Christine's setting up to try to help us address this, because it's a perennial issue in mental health. You cannot remove ligature points. What you can do is reduce the number of them and try to manage as best you can those that are left. And it does require the constant awareness, and it needs to be in staff's mind lots of the time alongside everything else they do need to do. So I do agree that some pan-trust communication. We can tell you what we are doing. Please do rest assured that we are reiterating this repeatedly to the staff, and it is very much in their minds, but it's a tricky old thing to get right. Thanks for raising that, Steve.
Thanks, Matthew. Right, we'll move on to Ian Dimond, please, on the operation report, and then the MSc, if you wish to comment at the end of that, please do. Thank you.
Thank you very much, Chair, and good morning, everyone. For those of you that haven't met me, my name's Ian Dimond. I'm the Chief Operating Officer here at Oxleas. So I'm going to start off by just presenting a few slides, which hopefully gives you an indication of current performance and a flavour of how the pandemic is currently impacting on the Trust and our response to it. And then following that, Yemisi and myself will talk about our mental health beds in a bit more detail. So, Joe, if you wouldn't mind just taking us to the next slide, please. Okay, hopefully everybody can see this. So the first slide really gives you an indication of how the pandemic is currently impacting on staff absence. These were figures that were from the beginning of this week. And for context, and this will become clearer on a later slide, we're currently experiencing about a quarter of the number of staff absences that we were at the height of the first wave of the pandemic. So it's, although it's proving, it is having an impact on our staff, it's within manageable levels at the moment. In terms of how the pandemic is affecting our inpatients, as Matthew said, we have had a number of outbreaks, but the number of COVID positive inpatients is currently small. And just to let colleagues know that Eltham Community Hospital, which is one of our intermediate care units, is being used as part of the COVID pathway. So we would, so what I mean by that is that by design, we are, if necessary, admitting patients with a diagnosis of COVID who are transferring over from colleagues at QE to help them alleviate pressures. But at the moment, things are looking pretty good. We continue to test all inpatients at the beginning of their admission, and we isolate them while we're waiting for the results. So this is something that we've been doing now for several months, and I think it works extremely well. In terms of prisons, you'll see that the number of confirmed cases have actually increased, and they're a lot higher in this than they were earlier on in the pandemic. The ones that are shown on the screen are the ones where we provide physical health care, and we have to provide this data. And you'll notice that Belmarsh in particular have had a number of confirmed cases of COVID amongst the prisoner population. You'll appreciate prisons are quite difficult environments to manage infection rates. It's unclear how infection got there in the first place, but obviously if you've got prison staff going in and out of the prisons, infection will come in and out of that environment. If we could just move on to the next slide, Joe. So this just gives you a kind of visual indication of the total number of staff absence due to sickness. So this is not just the COVID related absences, but this is the total. And again, you'll see that the kind of rates of sickness absence as of December are considerably lower than they were back in March, April, when we were at the height of the pandemic. So again, things are within manageable range at the moment. If we move on to the next slide. So again, this is just it's a rather busy slide, but again, it's a visual representation to show you how since April to date, COVID, the number of COVID inpatient cases throughout the duration of the pandemic to date. And as I've said already, we had significant numbers back in April at the height of the first wave. We had a considerable drop during the summer months and into September and October. And then we've had this resurgence in November, but currently we're on a downward trend. So if we could move on, Joe. So the next few slides are just to give you a flavour of some of our main operational indicators. And as I said, I'll talk a bit more about mental health bed management later on. So this first slide is a kind of visual representation of our mental health admissions. And there's a comparison there between our admissions for this year and our admissions for last year as an average. This year is represented by the red line, and last year is the blue line. So you'll see overall that admissions are down on last year. And I'll talk in a bit more detail later on, but particularly at the height of the first wave of the pandemic, admissions dropped off quite considerably. But I would say that they are, demand is back up to a kind of normal level at the moment. But we are generally seeing fewer admissions than last year. So if we can move on to the next slide. Okay, so before I kind of talk in a bit more detail about this one, the reason I've kind of chosen to highlight mental health admissions is that it's a pretty good indicator of how we're doing as a system to meet people's needs. So if we are experiencing high levels of admission, you can draw from that perhaps we need to think about how we're providing services to people in the community. So this is, although we provide a range of services within the organisation, mental health bed occupancy is a very important one, and we pay very close attention to. So this slide just looks at our bed usage in a slightly different way, and it indicates how we are performing when we compare demand to capacity. And some governor colleagues will remember that back at the height of the pandemic, where we saw a reduction in the number of admissions, we actually closed 3 wards, and 2 of those remain closed. And so that line, that black line, that gives you a sense of how many beds we've got at any given time. So as you'll see, back in April, we reduced the number of beds by closing 3 wards. We then reopened one of those at the end of May, beginning of June, and we've maintained the closure of 2 wards ever since then. What you can see is that our capacity, and I'll talk a bit more about this later on, but our demand is just outstripping capacity at the moment, but it is up and down. If we move on to the next slide. So one of the things that has been impacted by the pandemic is how we actually deliver services to service users. And this gives you a sense of how the way that we have contact with our service users has changed over time. So we adapted our offer to patients in the community, and this is across all service lines: mental health, physical health, and adult learning disability services and children's. And this gives you a sense of the proportion of contacts that we have with people, and how they're offered, proportionally face-to-face versus virtual, a kind of virtual contact. So at the height of the pandemic, we saw a reduction in face-to-face contacts and an increase in virtual, and that has again changed over time. So in terms of our community health services, the majority of our interventions have returned to being face-to-face. And you'll appreciate that a lot of the interventions for people with a physical health problem, by necessity, are kind of hands-on interventions. So although there are opportunities to do to carry out interventions virtually, and quite a lot of what we do has to be done face-to-face. In terms of mental health, it's currently around about 50% virtual and 50% face-to-face. And what I would say is that work is ongoing within all our directorates to kind of arrive at the right proportion of virtual to face-to-face contacts in what we call a kind of blended service model, which caters to both patient choice while still delivering good outcomes. And we undertook a really successful survey of service users earlier in the year, and we got some really rich qualitative data from them about how they experienced how we adapted our service model to meet their needs. So we're still working through that feedback to kind of arrive at a good position in terms of that blended service model. But I just wanted to highlight our IAP service. So IAP is our primary care mental health service that we deliver in Greenwich. IAP stands for Increasing Access to Psychological Therapies, and this is a service for people experiencing low-level depression and anxiety. And they have successfully changed their service offer so that it is now 100% virtual offer, and it's a mixture of different interventions: telephone, video call, and they've managed to do that without a decrease in the kind of outcomes that they're achieving, and also they've managed to maintain their access rate. So that's been a really positive story I just wanted to highlight. And then the last slide, if you wouldn't mind moving on, Joe. I mean, Matthew's already talked about the fact that we are very preoccupied about delays in accessing services. And I think it's important to state that a number of delays were created because of the pandemic, and the pandemic also exacerbated where we had existing delays in services. But what this slide demonstrates is that currently, well, first of all, I just wanted to say that the majority of our services are currently operating as normal. There are 2 or 3 which are currently closed, and that's because it's not possible to provide them safely and provide a kind of COVID secure environment. But the majority of services are open as normal. Unlike the first wave of the pandemic, we haven't had to invoke our business continuity plans. And so the services are working really hard to address the waits that we have and try and reduce unnecessary delays. So what the slide hopefully conveys is that a very high level, it gives you an idea of a very high level across all services of where things are at. And on average, our average waiting times are coming down, and the volume of people that we are able to see is slowly going up. And Matthew's already mentioned that our 2 big strategic pieces of work that we're taking forward next year is around having 0 delays and really improving the grade out of, having a great out of hospital offer. So these are indicators that we are very, very focused on as an exec. So I'm going to stop there before I talk a bit more about bed management in a minute, but I don't know if there are any questions from colleagues.
Any questions from anyone for Matthew at this stage? If not, Matthew, then Ian, sorry, Ian at this stage. If not, then move on, please.
Okay, thanks very much, Chair. So I haven't got slides for this, but myself and Yemisi just wanted to talk to you around our approach to our inpatient beds, mental health beds. So as a principle, our priority in delivering mental health care is for treatment to be, as far as possible, to be provided within the community. And I think what we see is that coming into hospital can be a very disruptive experience for both service users and their families, and therefore it's something that we only want to consider when all other options have been exhausted. And as a principle, this is something that we're trying to hold on to. The majority of the services that we provide to people are in the community, and a very small proportion of people use our beds. Last year, ahead of the pandemic, we began a piece of transformation work to reduce our reliance on beds and increase the availability of alternatives to admission, and really to think about how we strengthen our community offer. As I've already indicated, and some of the slides have already alluded to, the first wave of the pandemic resulted in a number of staffing pressures, allied with a reduction in demand for mental health beds. And we actually closed 3 wards, later reopening one of those. What we've seen is that there has been a resurgence in demand for admission since the summer. And I think it's fairly safe to say that we're back at pre-pandemic levels of demand. But I think it's important to hold on to, we have actually managed very comfortably, despite that, within our commissioned levels of bed capacity. And although, as one of the slides earlier indicated, we're not always able to operate within our revised actual bed base, having closed 2 wards. When you look at Oxleas bed usage in comparison to kind of national benchmarking data, it does actually suggest that we can potentially manage within this reduced bed base. And the way to kind of keep on top of that and to enable that to happen is to look at both ensuring that admission is purposeful, so we are admitting people for the right reasons in the right circumstances, and also that we manage how long people stay with us once they are admitted, and reducing unnecessary long lengths of stay, which are often caused because of kind of social factors, not because of health factors. So there are a number of programs of work which started prior to the pandemic and have continued during the pandemic. And these programs of work are both at a trust level, across the South London Mental Health Partnership, and across London as a whole. And actually, Matthew himself is leading some of these London programs and indeed the SLP programs. And all of these programs are very aligned, and they're quite systemic in nature, as in they bring together health together with a number of other partner agencies. And what they're looking to do is affect kind of transformational change, which will help us to get to a position we want to be at, which is being able to operate comfortably within a reduced bed number. And in order to do that, this will take some investment in our community services and some work to make sure that we are really focused on delivering good out of hospital care, which is of high quality and meets people's needs. I think although that there is some uncertainty about next year's financial settlement, I think that we have a good level assurance that there will be some targeted investment around mental health, and we as an exec are very cited on the need to focus that on our community mental health services. And if we do sustain a reduction to our mental health bed numbers, we would look to try and reinvest that from back out into the community. So I suppose what I'm saying is that we're proposing a direction of travel which sees us continuing to work within a reduced bed number and concentrating on delivering better community health provision, which is responsive to people's needs and actually reduces the need to come into hospital in the first place. And as I've indicated, there's a number of programs of work underway to address some of that. I think it's important to state, though, as the slides indicate, that in the meantime, and we have got quite high demand for beds. So to enable us to have a breathing space while we're doing this transformational work, we have purchased some capacity from the Priory to mitigate pressures over the winter. And by block booking capacity with one provider, it ensures a greater degree of quality assurance and efficiency to those who aren't placed in an Oxleas bed, because prior to that we have had cause to send people out of Oxleas into private beds, and this is a much better way of managing that demand, giving us some breathing space to get on with the work that we need to do, and which we anticipate will take us through the kind of winter period. So I'm going to stop there, and then I'm going to hand over to Yemisi, who will just talk a bit about the kind of assurance process around these proposals and where we've got to with that.
Can we just hold it for a second, if you don't mind? I missed, sorry, Councillor Yvonne Bear, you had a question to ask a bit earlier.
Thank you. Yeah, no, it was around this whole area that you've just gone on to give some more detail around, Ian. But I think the one bit that hasn't been touched on is what has happened to the 2 wards that we closed? Are they now repurposed for other use? And if push came to shove, could they be brought back in? as mental health wards, or have they now gone effectively?
Yeah, that's a really good question. So the wards are closed, and they haven't been repurposed for any other activity at the moment. Because of kind of staffing, the normal kind of staffing pressures, which were then exacerbated by COVID, the staff who were working on those wards were redeployed to other areas. So that would provide a challenge if we were to open up those wards. That's not something that we could do easily, because we would have to recruit new staff effectively to operate them. Hence why we've taken the option of commissioning block capacity over at the Priory. We have had conversations, and Matthew may want to say more about this, about whether those we have offered those wards to other colleagues in London, other trusts, to see if they wanted to work together on having some kind of winter surge capacity. But I think it's safe to say that there wasn't a lot of interest in that idea. I don't know if Matthew, if you want to come in on that.
No, I mean, the critical issue here is staffing. If we did want to reopen the wards, we'd have to go out to bank and agency, both for medical nursing staff and therapy staff. So it's the same problem for any trusts. That there are other trusts in London who are very short on beds just now, but it's not so much the physical capacity. It's they can't get the workforce in to run them. So that is a problem. And we are having a longer term conversation about the South London Partnership, because we do need more female PICU capacity, which is psychiatric sort of intensive care, where we have seen higher demand both in South West London and St George's and in Oxleas over the last couple of years. So we've considered whether there might be some options around female PICU in due course, but these are all still things for the future. I mean, the short answer at the minute, Councillor Bear, is that even if we wanted to reopen them, we couldn't without just bringing in a lot of outside staff. So I think the best thing for us to do is to stick to our guns and really focus on the good quality community transformation work that we're doing. Because if we can make sure that when people come in, it's because they really need to be in, and when they don't need to be in the ward anymore, we've worked with our partners to make sure that they've got a good, safe place to leave and go to, then I think that'll be in all of our interests longer term.
Councillor Bear?
Thank you. That's explained the situation. That's really what I wanted.
Okay, thanks very much. Missy, please.
Thank you, Chair. Morning, everybody. My name is Yemisi Gibbons. I'm a non-exec director at Oxleas, and I'm also chair of the Performance and Quality Assurance Committee, which we call PQAC. So around the mental health bed management that Ian has been talking about, we had a very productive and thorough review of it at our last PQAC meeting in November. It was attended by Simon Henley Castleton, who's head of the project management team responsible for this, and he was instrumental in collecting the data, doing all the background work and all the analytics, and it was really good to have him there because we were able to question and discuss with him a lot of the detail that was in the paper and around the management going forward. So we found that incredibly useful. Our discussions centred around service users. Obviously, we confirmed that a QIA was done, which is a quality impact assessment, as to how this was going to affect service users from every point. We wanted to understand more about how service provision would be enhanced by this move. So we spent a lot of time discussing that. We also progressed to talk, have discussions around the assurance around governance structures that have been put in place to ensure that they're robust, they're effective, they're fit for purpose, that they're well managed, and how they would be managed going forward. We talked about the mechanisms in place for reporting around many of the aspects that Ian has talked about average lengths of stay, about the private bed uses that he mentioned, out of area placements, benchmarking around other mental health trusts and how they were doing. We also discussed about the community service provision, which is vital to this piece of work, and how and the details around that and how that was going to be delivered. So we just kind of picked it apart slightly, just to ensure that we were perfectly happy with what was being proposed and the timelines involved and how the whole system would connect up. So and finally, we talked about the ongoing oversight that PQAC would have in terms of bed management, how we would get regular updates, if there were issues, how those issues would be solved. And I think at the end of it, we were all very confident that, in line with our new strategy of out of hospital care and improved care, that this was the right direction to go in. But knowing that it would be closely monitored and followed, to ensure that we got it right. So yes, thank you for that. But Ian and I are happy to take questions.
Thank you, Yemisi. Any questions for Ian or Yemisi? And even if I miss you, we can always come back. Okay, I can't see any on there unless everyone wants to sing out. If not, then thank you very much, Ian. Yeah, I know just how hard you've been working. It's been in tremendous pressure for all the teams, but I really do thank you for your personal effort and leadership that you put throughout this extremely challenging time. So thanks very much on behalf of us all for that. And thank you for your oversight of this challenging issue, Yemisi. We'll move on now to item 6 and the Partnership Committee update. Stephen Dilworth, please.
Thank you, Andy. I'm going to do this in conjunction with Matthew, so I'll give an overview first of all on the Partnership Committee, and then Matthew will go into how it works in a little bit more detail. Just as an introduction for myself, I'm Vice Chair of Oxleas, sit on the Partnership Committee, but also chair the Audit and Risk and sit on the Business Committee. The Partnership Committee was initially set up to coordinate and improve decision making within the South London Partnership, what we call the SLP. And as most of you will know, the SLP is 3 trusts working together, so that's ourselves, South London and Maudsley, and South West London and St George's. The Partnership Committee fundamentally then looks at that work that's being carried out there and the decisions through the SLP, but it also has a broader remit that has been developed to oversee all Oxleas partnerships. And that bit is particularly important because throughout the whole of the NHS sector now, the theme of and future direction is very much towards more collaboration and people working together, which makes a lot of sense because sharing good ideas, getting better efficiencies, and wider programs that individual organisations often wouldn't be able to do by themselves. As in our covering paper, you'll see that governors have been able to observe the meetings of the committee, and we have 3 non-executives who are involved in the Partnership Committee. So that's myself, Joe Stimson, who chairs the committee, and Andy Trotter, our chair. All 3 organisations within the South London Partnership have similar committees, and so when we meet together, we call that the Committees in Common meeting. So what's the benefit of this group? I mentioned before, it smooths the processes that we work, and it oversees the operation of our various partnerships with many organisations. But prior to this, and particularly if I look at the SLP, one of the difficulties we used to have, we'd meet as the partnership board, we'd make a decision there, it would then have to normally go back to all the individual subcommittees of the various boards for further scrutiny, probably then a further meeting at the boards for South West London St George's, South London Maudsley and ourselves. So it was quite a torturous and slow process. You know, from an initial decision, it might be another 3-4 months before it was ratified. So that speeds up that process quite substantially. It enables us to move a lot more quickly, and obviously that is better for service users and better for the individual organisations, because it makes sure that we get programs up and running much more quickly than we ever have done before. Good for the organisations, good for the health of local people and local communities. I'm now going to hand over to Matthew, our Chief Executive, to give a little bit more detail on the committees and the benefits of how they've worked. Over.
Thanks, Stephen. I mentioned the ICS update earlier, and partnership working is becoming an increasingly big part of how the NHS needs to approach its challenges of delivering services in the year ahead. And the South London Partnership is, I think, probably an exemplar nationally of how trusts can come together across a population area and work together in the best interest of that population. Many of you will, like me, remember the 2012 Health and Care Act, which was designed to introduce clinical commissioning groups, CCGs, which are now going through a process of quite significant change. But I have to say, in my experience in the NHS, the best clinically led service developments I've seen across a patch have been through initiatives like the South London Partnership, where you do identify a population need, you get a group of clinicians together and you say, look, what can you do here to work together to get better outcomes for them? And what we've seen in the South London Partnership is that we've been able to reduce the number of Londoners who've been sent out of London, so reduce the number of children sent across the country for CAMHS treatment, to reduce the number of people needing forensic care who've been sent outside of London for their care and treatment as well. And by bringing those people and their care back into London, we've improved their length of stay, we've improved the quality of care they've had, but we've also saved a lot of money that was previously being spent outside of London. And that money's allowed us to invest in new services as well. So if you're delivering healthcare and you can improve quality and save money and reinvest that money in better services, that really is the job these days. And actually the South London Partnership has been able to do that in a way where actually the clinical practitioners have been at the forefront of it. And it's not just the NHS, actually. As part of the South London Partnership on forensics, for example, we work with a number of private sector and independent sector providers who are a really important part of what we do, because they offer specialist care, they offer additional capacity and input, and they're every bit a part of that partnership alongside us. And I think we've seen this year that actually, you know, the NHS has used the independent sector to help us with elective backlogs and all kinds of things. So this isn't something just about the NHS, it's about all the services that come together to deliver it. And as we're delivering new partnerships in things like complex care, the local authority engagement becomes a really important part of that, because lots of these people we're caring for a long time, they need a safe place to live for the rest of their lives, and they need care and support through that. So it's genuinely about partnerships in all kinds of different directions. And something we introduced also recently is a partnership committee with Lewisham and Greenwich Trust, and we now meet with them. And after, I suppose if we're honest, we had a couple of quite spiky discussions in the first one. I mean, Steve James is our sort of shared NED with them, and I think it's fair to say that the acute trusts and mental health trusts and others, you know, sometimes we have a slightly fractious relationships, and you know, because we tend to talk most when things aren't quite working as smoothly as they could. But that's been a great forum for us to get together between the two trusts and get into a position where we're much more recognising that we've got far more in common than we have that divides us. Actually, you know, we're all about the same things, and it's really helped us improve those dialogues. And really, when you get those better conversations going, what you get is better patient care and better staff experience, and that's the real trick. And then, you know, likewise, the kind of work we're doing in Bexley through Bexley Care has been really important for us. In Bromley, where we've got a pilot starting in our primary care network there about better primary care support for people with mental health problems, and in Greenwich through our mental health alliance, and also in Greenwich the Home First physical healthcare work we're doing across Greenwich and Bexley, which I think we might hear more about later today, but a really great initiative to reduce length of stay in hospital and deliver more complex physical healthcare in people's homes. So I mean, Oxleas is a trust doesn't just say partnership matters to us. We actually prove that partnership matters to us through the way that we deliver services. It's a really important thing that runs through everything we do. And I think when you look at the national policy direction, where they're now seeking to legislate to get partnership working, I think we as a trust, we're doing the right things here. And I would like us to speak more to the governors next year about what more we can do, both to bring in our voluntary sector and other community partners more, because I feel as though their voice probably needs to be heard more within what we do. And I think if we look at some of the developments we've got going on in Greenwich around crisis housing, etc., I think there's real potential there for us to speak more to people who, frankly, can do a better job than us in some of the areas where statutory services are very stretched. And I think the other sort of piece of, it's a different kind of partnership working, but I think as a trust we need to think about our service users and carers as partners more in how we deliver care as well. And I know we've got a number of carers governors, and I think there's an opportunity for us in 2021 to have some conversations with you as the governors about how we can really focus on that service user and carer voice as an important partnership relationship. Because healthcare isn't just about us working with other healthcare providers. It's about recognising that lots of you are carers for people as well, and you provide a lot of care too. So as we think about partnership dimensions going into 2021, it's not just these great statutory bits that we've got in motion. It's actually thinking about all these different aspects of care. But can I just say thanks to Stephen and to the governors and others who are part of these partnership discussions, because they really are a tremendously satisfying part of service delivery at Oxleas, and we're a trust that I think does it well alongside SLAM in South West London and the SLP at a level where we're leading nationally on this. So thank you, and very happy, I think, for Stephen and I to take any questions.
Thank you, Matthew. Thank you, Stephen. Any questions on that report? Really good. So many really positive developments there across the partnerships. In the absence of anything that I can see on the screen at the moment, thank you very much indeed. And we'll move on to the next item 7, the South London Partnership. And I think we've got on this one, that's Peter Brearley and James Asfer presenting on this one. Is that correct, Sally? Yeah, Peter, I can see you there, Peter.
On the call.
Hi, Andy. Thank you very much, Governors and Oxleas, for inviting us to talk to you. We've got Pete Brearley from Citizens UK and Danielle, who's going to share a presentation, working on this, working perfectly. So I wanted to say there was a briefing note that was circulated earlier, and so I won't go through this in much detail, but this follows perfectly Matthew's discussion around the South London Partnership. What we've recognised is that with COVID, there is a definite impact on people's mental well-being. And whilst as a mental health trust, we don't provide primary interventions, what we know is we can't stand by. And actually, we need to be able to reach into our communities to be able to support them as they've had an impact of mental health as a result of COVID. So I'll take you through a series of slides which talks about the South London Listens campaign, which we launched at a summit on the 10th of November. Here's some pictures of a summit that we held on that date, all virtual. I'm absolutely amazed that we're all moved to a virtual world in such perfection. I should say I'm the Director of Communications at South West London and St George's. So can we just go to the next slide, please? So this was some of the background that actually we all know. We all know somebody who's been impacted by either COVID-19 or the impact that it's having on people's lives, whether it's the impact of the economy, and we know that there's prediction of job losses. We know that the government has said that we're headed for the worst recession since World War II, and the headlines speak for themselves. We also know that anxiety is on the rise, and many people who have never been known to mental health services are getting in touch. And what we want to do is to be able to reach out to our communities and to be able to get in there early, to be able to support people and give people the tools that they need to be able to manage their mental well-being. And this is very much about giving people that support rather than waiting until people get unwell and start to use our mental health services. And this is about how do we work with our partners in the community and voluntary sector, as well as statutory organisations, to be able to look at what we can do to put in place. Next slide, please, Danielle. So just to give you a little bit of background, so since June, we've been listening and talking to our communities across South London. We've reached out to about 2,000 people so far. And through those listening events, what we've had in the summits, we've identified 6 major ambitions that we want to be able to tackle as a partnership. And I won't read all of these out, but I'm sure you can relate to some of these being something that you'll understand is important that we need to work on. And also, so you'll recognise that some of these are aspects that we have to work in partnership with our partners to be able to deliver on, and are not able to deliver ourselves. So this is why this piece of work is so important, that we do work in partnership with our communities. And we've developed a task force which has got representation from across South London, from our from community and voluntary sector organisations, as well as statutory and people with lived experience. So that's really helped us shape this. But what we recognise really importantly is actually we can't create a top-down program. This is not about us thinking we know what's best. This is fundamentally about listening to our communities and understanding what do they need, what tools, support do they need to be able to help them manage their mental health and their family's mental health and their community's mental health. So I'm really grateful for the support of Oxleas and grateful for this opportunity. I'll probably hand over to Pete actually just to talk a little bit about what Citizens UK, who are a partner organisation that we're working with, what they do, and to explain a little bit about the South London Listens campaign. Pete, are you okay to take us through? Yeah.
I'm hoping you can hear me this time, because last time
we can hear you.
Okay, wonderful. Great to be with you all, and exciting that the three trusts are working so well together on this, and really good that it came after Stephen and Matthew's presentation about actually what we can do together is much more significant than what we can do on our own, and that includes obviously the trust working together, but it also includes working with our local authorities, working with our local community organisations as well. As Ranjit said, my name is Pete Briley. I'm from an organisation called Citizens UK that kind of uses community organising practices to make change. And if you haven't heard of Citizens, you might have heard of the Living Wage campaign, which is a campaign that was started by citizens and started actually in the back of community organisations in universities, churches, mosques and synagogues in East London, where people were saying we don't have enough food to put on the table. And rather than set up food banks, they decided they would start a campaign to get better wages for people. And obviously we know that campaign, which started with listening, has now involved local authorities, involves all sorts of businesses, and has put billions of pounds of money into the pockets of some of the poorest people across the UK. So listening is not just about listening to people, it's also about taking action, and we're very keen that the end of this is about taking action. So the listening, which we're inviting really all of you and communities that you're a part of and people you're connected to be involved in, is about kind of involving people in the process of coming up with creative ideas, and putting people who are closest to the pain as part of coming up with some of the solutions. And I'll just tell one very brief story about how this has worked elsewhere to kind of give you a flavour of what it will look like. We were working actually with South West London in Merton, and we were doing some listening with some schools in there. And one of the schools, Wimbledon College, there was a young lad who was, struggling not with really serious issues, but was struggling with kind of some mental health problems. And he decided he'd bring some of his friends together to see what they were experiencing and how they were dealing with it. Then they decided they'd get involved with the school next door, and they also started to talk about what they could do. And they talked about two things. They talked about, number one, what could they do as individuals, as young people in their school? How could they be supportive of other young people who are struggling with this? And that led to kind of some peer mentoring in their school. But they also started to realize that there was a theme around, I think it was specifically around, and forgive me, I'm not a mental health expert like lots of you, but I think it was tier 2 kind of accessing support. And there was a particular place in the borough where they would have to access it. And it was basically the other side of the borough to where they were. And they discovered, as they started to talk to lots more young people, that this was a common theme. And so they started to work with the CCG and the Mental Health Trust, and they said, is this something that we might be able to change so that we feel more comfortable to access the services? And it was a no-brainer, really, and the CCG and the Mental Health Trust were able to kind of create multiple access for people to get that tier 2 level support. So not only had the kind of the energy and the enthusiasm and the willingness of those young people been activated through the process of listening, but there'd also been some substantial change that meant that the service was better fit for use. and everybody was happy about it. So we'd love you to be part of this. I think there's some people from your different boroughs that have already been involved in the training, and there's a training that we're putting on about what you need to do in order to be part of this. And the next training for that is the 6th and 7th of January, and I'd love to see some of you there. And we can send you, I think there's probably details in the chat. I don't know if Danielle's going to put it in, where you can sign up, send it to other people from the voluntary sector and other places where you're working.
Thanks very much, Peter. Ranjit, is there anything more from yourselves?
No, thank you, Andy. Only just to reinforce what Peter said, this is really an important opportunity for us to be able to reach out and to listen to our communities, and the work and the solutions that we come up with will only be as good as what that listening tells us. And we're absolutely keen that this is from the grassroots up. So very happy to take any questions, and thank you for listening.
No, well done. Thanks very much indeed, both of you. Any questions for Ranjit or Peter, please? There's the contact is on the chat now for those who want to get in contact. I'm very grateful for everything you're doing so far. Very exciting project. Is there anything else from anybody else on this before we have a break? If there is no, yes, please.
Yeah, it's Richard Dimond here, for anyone who hasn't picked up. Three things. First of all, is it possible to have the slides we've just been shown shared with us? The second one is, apologies, I didn't make the meeting that you had a few weeks ago, but I managed to persuade one of my fellow councillors in Bexley who had a particular interest in the area to cover the meeting, and I know she was very complimentary and found it really helpful and wants to get engaged. And the third one, which really a suggestion, I know a note's gone out this week to try to get the council leaders and relevant cabinet members in the local authorities engaged in this to a greater extent, and certainly do anything I can in Bexley to achieve that. But I'm wondering, to what extent have you tried engaging with particularly the chairman and maybe the members of local authority overview and scrutiny committees that have particular responsibilities in this area for how things are being dealt with? So I think they may well be an important group for you to make contact with and make sure that they're aware of what's going on. Thank you.
I can answer some of those questions. Richard, thank you very much for those, and absolutely we'll share the slides, and really thank you for the feedback on the summit. So we've had a number of conversations with the leaders of the council who've all been really supportive, and we're doing the rounds with various health and wellbeing boards. So our hope is, through the roundtable discussion with council leaders, we'll be able to get more stimulus with elected members. But I think I take your point, which is a really good one, and we will reach out to those groups. And I think fundamentally, elected councillors have a real key role as well to play in terms of engaging their constituents. So I think this is truly a partnership approach. So thank you for that, Richard.
Yeah, thanks, Ranjit. Sally, please. Sally Brightman.
Yes, just to say, we will send out a pack of information to all governors and to give you a bit more detail of how to get involved, and very much want to link in with you and your communities so that we can really sort of spread through our networks, and particularly with our partnership local authority governors, work with you to kind of spread the word within our local councils, because you know, this is an idea that's sort of growing and really want to make the most of it.
The only thing I'd add, actually, apologies for coming in again, thanks, Ali, is just the timing on this. It was launched on the 10th of November at the summit. We'd really like people to have done the listening by the end of January, which means getting people to the 6th and 7th is pretty crucial. Obviously, I imagine most people are starting to switch off for Christmas and put their lights up, like me, Christmas tree in the background. But hopefully in the new year, kind of fresh energy and impetus, a bit of a break, it gives people an opportunity to do that before January's out.
Thank you, Peter, and a very tasteful tree as well, I must say, so looking at it from here. So, but, Sally, do you want to come back in?
I've just had a query through from Ray. He was just mentioning about house meetings and about he's just wondering how they'll work within COVID situation, or is it all virtual?
Yes, at the moment, most of the people that are doing this are doing. Sorry, for those who don't know, a house meeting is basically a small group of people that get together between sort of 5 and 12 people. They're called house meetings because it started in the States as part of the civil rights movement. That's what they were called. So we've kind of adopted that terminology. But most people are choosing to do them online. There are obviously some kind of faith organisations that are still meeting kind of COVID safe, and so some of them are doing them physically. Some people are aware that they can't do things via Zoom or via, I don't know what it is you use, WebEx, and so they're actually doing kind of phone trees, and they're actually phoning people and doing it that way. So if you come to the training, we talk about the different ways that you could potentially do it, but I'm sure you've got creative ways yourselves of thinking through that.
Okay, Sally. Well done on that. Thanks. So again, repeat my thanks, Peter, Ranji. Thanks very much indeed. I'm very grateful for your input on that, and thank you for everything you're doing. We're going to have a break, folks. Will 9 minutes be enough? Yes, I'm getting nods. 9 minutes enough. So if we come back at 11:30, is that okay, everyone? Right, 11:30 it is. Thank you. Director of Therapies. Welcome, Neil. I think this must be your first Council of Governors as Director of Therapies. Could you introduce yourself and then over to you?
Thanks very much, Andy. Yeah, so I start on the 1st of January as Director of Therapies. Really looking forward to that because it combines both Director of Therapies and patient experiences, which is two of my kind of great interests. So today I will try and share the slides for this. If I'm...
Yeah.
Oh, great. So Joe's doing that. That's much better. Yeah, so I wanted to talk to you about a substantial piece of work to do with remote consultations during COVID-19. The context for this, I think, is that for years we have been trying to think whether remote working would give us advantages in healthcare. The technology was always there, but actually many sort of human factors came in the way that people were not trusting this. I'm very aware that I sort of didn't use it very much in my own life. And it took a massive crisis like COVID-19 to force us to use the existing technology that was there. One of the quite frightening things about this, though, is that that there are many barriers in healthcare to do with communication. These can have huge impacts on help seeking and all the rest. So we really needed to get things right about how we can work with our service users to kind of get the human factors right as well as the technological factors. And so the patient experience team were keen to just try and understand what the experience was of our service users who were using this technology, bearing in mind that they were doing so when they were asking for help. They may be in distress and across a range of health conditions. I thought it was really great that the patient experience team would come to ResearchNet, and ResearchNet is one of the ways that we gather patient experience, because actually in our ResearchNet group we have many people who use services, and actually the kind of questions we wanted to ask were not just about technological barriers or a digital exclusion. It was about the experience of seeking help, which I think only service users can describe. So Joe, if you could go to the next slide, please. So I'm not going to read all of these questions, but these were questions that were generated with ResearchNet and with the patient experience team. And I was part of that discussion in ResearchNet, and I thought it was fascinating because there were many issues around the user experience of working with health professionals, anxieties about whether extra shame would be created if you had to ask your mental health provider or your health provider to help you with the technology. We realized that many of us were not aware of what kind of phone contracts we were on, so there might be a financial implication, you know, and if people were presented with bills that they weren't expecting, this could be really terrifying for them. So the questions we came up with, 10 there, and we shared them with the patient experience team, and they were able to sort of modify them and reduce them. And you can see from that that this really does have the whole experience of what it's like to seek help, what it's like to actually also need help, not just for your health condition, but to make the technology work if you're not used to it. It's like a sort of many sort of problems coming together. So we were able to take these 10 questions, and Joe, if you could go to the next slide. We were able to survey 35,000 of our patients, and you can see that actually the survey we chose to do was between 22nd of June and 17th of August, but we were looking at contacts since COVID began. So I do want to highlight that 17th of June, 17th of August cutoff figure, because actually I think this is showing something about the early phases of COVID. In the next line, you can see ACH is adult community health, AMH is adult mental health, older people's mental health, ALD, children and young people. You can see how many returns there was from each. And not surprisingly, perhaps older people's mental health 17, because we're doing this survey remotely as well. But we got a 14% response rate, which is good for a survey. And that amounts to 5,054 people responding about their experience. In the pie chart below, you can see the green is telephone contacts. So the majority during the early period of COVID was telephone contacts. 11% was video call. I would be interested now to see whether we've shifted between the sort of telephone and video because we are more used to it. And 7% was a combination, and also text messaging. And you know, my own experience as a clinician was I was using all of those methods. Joe, could you just go to the next slide? So in response, and there is a very fulsome document written about this, but the headline really from the survey was that 90% responded that they were happy or somewhat happy with services during COVID using those remote methods. They highlighted some really important things, which I think we need to think about. That there was a preference for remote consultations when people had already met their clinician. And when you look into the data, people are talking about that was because they already had a rapport through face-to-face contacts. And actually, that rapport was able to be carried on once they had moved to virtual means. There was a preference for video consultations over telephone, but people would accept a combination. And it's interesting because actually we did a lot of telephone work in that time. So people were even then saying they preferred to be able to see somebody. And that actually going forward, there's a strong indication that actually our service users in all areas would prefer a choice of remote appointments as treatment progresses and for follow-ups. So a strong theme of it does seem to impact people's experience of rapport building and trust at the beginning. But if trust is established, people actually found this quite convenient to be able to have remote consultations for follow-up. So a number of really interesting comments, like people were suddenly having to do much more childcare or other caring arrangements. So it's easier for them to kind of come into these consultations. And actually, that's something that we do really want to try and sort of get hold of, because it was always our intention to try and think, could we get a mixed economy of the ways that we using new technology to relate to people. You could just go to the last slide, Joe. So in conclusion, there are some, I think this has some implications that certainly I think it'd be useful for us to think about. We found that there was a whole new area of digital exclusion that perhaps we weren't aware of. And since this, we've picked up that a number of our teams are making applications to our trust funds, and our trust funds are used for patient benefit. And actually, some of the experiments that we'll be doing with lending people iPads for the duration of their treatment, trying to help those so that the digital exclusion does not become a barrier, is very, very useful. We're also picking up early indications that some of the third sector around us are seeing this as another form of inequality and trying to address digital exclusion. So we're in a later phase of the pandemic, so we're seeing more and more kind of reactions, which is why I thought it was important that all of the data we've looked at is prior to August. Some of our clinicians are telling us anecdotally that they're seeing a reduction in DNAs, and I know this from my own practice. So I've noticed that the attendance at our groups now is much more consistent, because even when people are working in adult mental health, and I can give you an example of somebody who was feeling really, really bad. So they took themselves away to go for a long drive in the forest. And actually, they suddenly realized they would be missing their group. And so they did their group from their car on their phone. And this gives people almost another option to be able to opt back into appointments that they would otherwise have completely missed. Next, I think we should consider that actually our expertise is improving. I've certainly got a lot better at doing therapy online. I'm really aware that now I think a lot of the therapy and groups that I'm doing are actually really resembling face-to-face therapy for their depth and the quality. I do want to highlight something about our Sun groups, which was a particular type of group for people with personality disorder to manage risk. These were really challenging to get back online because they are drop-in groups. And there's a number of risk issues about locating where a service user is or managing confidentiality. And actually, we've been now able to develop a protocol, which we've piloted, to just manage those high levels of risk by having a new consent process for people to join those groups. I think 2 weeks ago, we had one of our quite typical kind of risky incidents happen in those groups. These groups are designed for that. And it was managed really successfully, where an ambulance was called for somebody, and we were able to monitor that through the virtual means. This is a real breakthrough, and I think can offer, perhaps in a mixed economy going forward, something much more to our service users. And it's because we are getting better at these things. Perhaps we are, as we are in our own lives as well. And lastly, it's possible that this new form of remote access may actually help us with our recruitment crisis in London. That I was aware that a few people are being employed where sometimes they would come in and sometimes they may be working from home. And this is perhaps something that would be useful for us to consider, because this is impacting all areas of industry. I know it's massively impacting the university sector, where people can come in remotely and you can get a range of expertise without having to rely on being able to fight your way through the South Circular all the time. So I want to just conclude there, very much a headline. Thank you for sharing, Joe. And I don't know if there are any questions or comments about that.
Yeah, thank you very much indeed, Neil. That's really, really good. Stephen Turner, you had a question about if people DNA, say, on 2 appointments. Stephen? I don't know if Stephen Turner can hear.
Hi. I did text my question. I'm sure you've picked it up. It just, I'm aware that some of...
I would assume it was yours, yes. Sorry.
It just how you follow up if there are DNAs and what you do about them, because obviously in the normal circumstances of people who DNA hospital appointments, etc., they are followed up, and it's obviously a bit more difficult with just telephone or video conferences. And I just wondered if you had a policy in place for that. Thank you.
Yeah, you're welcome. No, we do follow people up with DNAs because obviously, in a way, that process does map quite well onto remote working, because we would still need to use text or phone calls to follow up on DNAs. One of the issues for us is not necessarily DNAs, but people leaving groups or sessions in distress and being able to locate them. And that actually we seem to be getting better at sort of finding ways of communicating to people. They will need to let us know where they are and to follow up the risk that way. So for us, that's something that I think we've been tested on, and we are learning about that. But we do a lot of our processes for DNAs still stand and actually have been working quite successfully.
Thank you, Neil. Thank you, Sue, for that question. If there's nothing else for you, Neil, thank you very much indeed. And it is remarkable how we've moved so quickly, isn't it, to use
Absolutely.
the technology we've had for a long time. And certainly something we'll be using post-COVID, no doubt, with some rather more enthusiasm than we did before.
Sorry, Andy, I've got a question. I put my hand up.
Sorry, who was that? I can't see.
It's Cassandra.
Yeah, go ahead, Cassandra.
Yeah, I was just going to, so I'm from Bridge Support, with a forensic partnership governor, and we also run the Recovery College in Greenwich. And so we've moved heavily online, all online, doing COVID pandemic. So it's just a sort of, I think you referenced digital poverty, and I see that there's Steve Turner has loaned some tablets to Oxleas for service users to use. I just wanted to flag up, it's not just once the device is in place, it's obviously not just the device that holds people back, it's also the free, it's the unlimited broadband. Our experience tells us that that's what was holding people back. People had potentially sometimes mobile phones, but then didn't have the contract, if you did reference this, to be able to have, to use the amount of bandwidth that they would use up all of their plan on having one Zoom call or one Teams call or whichever platform you're using. So that was just something to flag up. It's not just the sort of once you've got online, it's once you've got the tablet or the mechanism to do it, it's actually the ongoing cost of being online. But I think you can reference that. And I suppose the other thing, just as well as running a recovery college, Bridge also provides community support to people in Greenwich, people with mental health problems. So it's just we have also done lots of phone calls and lots of phone support, and we know that that's been really helpful. But and I think you've acknowledged this. It doesn't replace. It's always it's another way of getting to people, but it doesn't replace the face-to-face stuff. There's stuff that you will miss if you don't see people face to face. So I suppose it's just to add that in, because and in reference back to Sue's point about people not turning up, it's just that how do you keep tabs on those people? But it sounds like a really really good initiative, and it's just how do we make sure, as you say, that we go forward with a mixed offer, as opposed to this is what we're doing now sort of thing.
Thank you, Cassandra. It sounds like a lot of similarities between our two experiences.
Yeah, thanks for that, Cassandra.
I wanted to ask a question as well. It's Leslie. I'm having problems with my laptop. How does it work when you're doing like the video sessions? Because you can't always pick up how a person is feeling when it's not in a personal room, in a room face to face, because sometimes the picture fades, or so you don't get a correct sense of how that person is. How are you dealing with that?
So I would agree that this does not replace face-to-face, but pragmatically it seems to give people more chances. Leslie, I would say that's our experience is that's a lot to do with the skill of the clinicians in being able to bridge that with communication. We've seen some really good examples of this working, where people are actually working together, to try and overcome those difficulties, and that itself has helped the kind of contacts. But I think you're absolutely right. This is something that we need to keep working on, and these are not technological factors, they're human factors. They're to do with communication and the skill of our staff. And I think that's also what we're improving on, is learning how to communicate when everything is going, your picture's frozen and all those things. And just looking at my colleagues, I can see that actually this is very much actively part of supervision discussions in how to make that work. But it will always be part of a mixed picture, I think, for us.
Okay, thank you.
Thank you, Leslie.
And I would just like to add, I agree with you about the hours, the flexible hours for the staff. I think that's really important, to be flexible with the staff rotas. I think that helps. Thank you.
Matthew, please.
Thanks, Andy. And I mean, I think this is a fantastic piece of work, and it's also lovely to hear Neil talking in his not quite in his new role, but close enough. I've been really interested in this digital access to therapies, because I think it's fascinating. We know that when we offer people who use our services the chance to book stuff themselves, that they probably choose different times to the ones we might offer to them otherwise. They look for stuff that's more flexible around their own lives. I think it's also important. A friend of mine who's a therapist, she's got very mixed views about it for certain patients, because she's talked about the importance of routine and getting people out of the house sometimes. And actually, if you've got someone with chronic anxiety, actually allowing them to do their therapy from their bedroom is not necessarily the best thing. And actually, that routine of getting, I mean, it's interesting if you go and talk to some of our services that work with people with very long-term severe mental illness. They talk about the importance of the routine of getting up and having a shave, if you're a man, of getting dressed and going to work. Those kinds of things, the things that get you out of yourself and create that routine. So, and I think one of the things about COVID is it's kind of forced us into a bit of an all or nothing. And so we've had to adopt digital therapy en masse because the alternative is to withdraw treatment in some cases. And we've seen it with some of our very hands-on physical treatments that the waiting lists have exploded as a result. And we've managed to do well on that. About going forward from this year, this is about offering a really good, clinically appropriate digital service as part of a whole therapeutic offering. And making sure that we have the right tools to do digital therapy well, the right tools to do face-to-face therapy well in safe, appropriate environments for the people for whom it's most appropriate, to assure our staff that we've protected them, but also to assure our patients and service users that they can exert a bit more choice about the mix of things they want to choose. I mean, one of the digital app pilots showed that if you let people choose their own sessions, they tend to pull them together more and they have a more intensive spell of therapy, then we might string them out over a slightly longer period. And we need to understand, is that better for outcomes or not as good for outcomes? It's a great learning opportunity. And as we move out the thick of the pandemic, the important thing is that we bake in this learning and this becomes a really important part of a whole service offer, not just it's this or nothing, because longer term, for some people, that face-to-face emotional connection will be an important part of getting better and staying well.
Thank you, Matthew. Stephen Dilworth, do you want to come in?
Yeah, thanks, Andy. Two quick observations. Excellent research, Neil, and so very, very useful for us. Two things that quickly strike me. One about the DNAs, do not attends, which does have a massive impact on us. We experience about a 10% rate. But I think what the virtual connection does allow us to do is give us a bit more flexibility. If someone doesn't connect, you can move on to another call. So that has been useful. And secondly, I take Matthew's point about anxiety issues, but we have had some feedback, particularly from prenatal groups, that for some of the service users, it's quite good that they initially connect virtually because they're a little bit reticent or shy when we were having physical meetings to actually come along to a physical meeting to groups of people that they didn't know. So sort of doing the virtual connection first and then at a later date attending a physical meeting actually for some of the service users works quite well. So a lot of benefits, again, that sort of mixed service approach that Matthew.
Absolutely. I think you described it really well, Stephen. It will help us with stepped care, helping anxious people gradually come into services. I am now working with people that I have never met physically, and I'm seeing much better results than I thought, but we need to tailor this to particular individual cases, but it gives us more flexibility, perhaps.
Thank you, Neil. Sally had a question on behalf of Ray.
Yes, Ray would like to raise, how do we remain in touch with prisoners?
Yeah.
Do you want me to come in on that, Neil?
Yes, please, yeah.
Yeah, certainly. I mean, we have had the prisons has been very difficult during the pandemic. I mean, our staff have been going in and delivering the care that they can. And we have actually spoken to, I think it's West Yorkshire, who run prison services and make a great use of digital technology actually to offer all kinds of appointments to prisoners. And there are issues with it. The technology has to be physically very robust, as well as safely offered to deal with some of the pressures of that. But certainly Keith and I met West Yorkshire just before the pandemic kicked off to talk about the potential around some of this technology, because I think in the prisons at the minute, they have had to deal with, very constrained environments, to deal with some really quite intense emotional pressures this year as well, worse than usual. And I think there is something about us losing some of this digital understanding. Think, is there a different way to offer access to certain kinds of health service in prisons without us necessarily having to physically send members of staff in repeatedly? So I think it's an area for exploration. I think we need to think about how we use digital there in an appropriate and safe way. And I think that there is also something about staff protection in this as well. There's maybe some good routes to this. It is also, though, it's always dependent on the prison regime being able to support us. If you do have a digital suite in a prison, you still need the prison to be able to bring the prisoners out their cells, bring them along to have their appointments. So there's all kinds of other factors around it. But I think West Yorkshire managed to make some pretty good use of it. And it's something I'd like to see Oxleas looking at a bit further in the months and years ahead. We've got a great pilot about to start at the Bracton Centre, our forensic service, using virtual reality as a route into mechanics training, car mechanics. And then we've just agreed as part of the South London Partnership to do this. You know, you can't take someone out of a forensic setting and put them in a full garage. But what you can do using virtual reality is bring them into a garage environment. And we're doing this work with First Step Trust, who are a charitable provider in Woolwich, and they've got a garage in the Crays and others. And this means that people in the forensics pathway can come out the service, having learned the basics of mechanics, and then go into a garage that looks exactly like the virtual reality one they've been practicing in, and take those skills into the workplace. And I think Andy and I both had a go on the virtual reality headsets. They're really quite incredible. I mean, I took my own car into First Step to have them do a service on it a few months ago, because they offer good rates for Oxleas staff and members, I should say. And it was fascinating to see that this place I'd been in before on virtual reality. The garage is exactly the same as it, and it's a really interesting way of using these technologies to think about everyone under our care and how we offer all kinds of different therapy there. But important that it's part of a mixed digital offering, so the right people get the right care at the time they need it.
Yeah, thanks, Matthew. There's a question there from Sue about can this be repeated when COVID is not their reason for remote working in the future? Neil.
I think that would be very, very interesting, because I think this is a fast changing situation, both in terms of the context and in terms of our learning. And I think that would be a very interesting idea for us to consider, because that would be a way, I think, of making sure this is part of the offer and seeing how it works. But I think it has really lifted us to something that we have been wanting to do for a long time, but were forced by a crisis to experiment with. So I think that would be really useful.
Thank you. Well done. Thanks very much indeed, Neil. So much interest this has generated. So I'm really grateful. Thank you very much. So we'll move on to the next item, please. Item 9, and this is Jane Wells, learning from serious incidents. Jane and Stephen Dilworth on this one, please. Thank you.
Thank you. I'm just trying to find the slide to share. Hopefully you can see that. Yep.
Yep.
So this was an incident that happened on one of our older people's mental health wards in July, and the panel that investigated it included the Governor John Crowley and Non-Executive Director Steve Dilworth. I reported this to the board recently, so apologies to anybody who has already heard this. So our patient was referred to the Older People's Community Mental Health team at the end of June. She was presenting for the first time in her life with hallucinations and low mood, and she didn't actually have a history of mental health problems, and she hadn't been involved with services previously. But what she did have was a wide range of comorbidities, long-term conditions and underlying health problems. She was quite frail. So she was admitted to the emergency department with a working diagnosis of an organic psychosis. She was seen by the mental health liaison team. She was transferred very quickly to Shepherd Lee's ward, which is at Oxleas House. And she was then detained under Section 2 of the Mental Health Act. And sadly, a few days into her admission, during the early hours of the morning, she was found unresponsive and not breathing in her room. And the staff correctly donned the right aerosol generating procedure, personal protective equipment, because of COVID, so that they could start cardiopulmonary resuscitation. But unfortunately, our patient was pronounced dead on the ward and couldn't be resuscitated. I'm sure I've mentioned before, but it's actually very unusual for us to have people with cardiac arrests on our older people's wards. We often wouldn't be surprised if we would think, would this person be alive in 6 to 12 months? But actually our staff don't encounter these very often. So the team that were on duty did a really good job, and we didn't find any problems there. In terms of the investigation, we didn't find a root cause, we didn't find any contributory factors, and we didn't find any care or service delivery problems. So no recommendations were made. However, what we did identify was just some reflective learning points for the team which have been followed up. And the first one is it's usual that the liaison team and the ward will have a discussion where there is a suspicion of delirium. And although the admission was quickly and appropriately carried out, they didn't have that discussion in this case, but it didn't make any difference to the outcome. Also, given the age and the frailty and physical health comorbidities of our patient, we did think maybe a discussion a few days earlier about do not attempt resuscitation should the needs arise may have been considered. We have a trust-wide quality improvement group looking at this, led by Tom Clark, who is one of the deputy medical directors. But this is within the context of advanced care planning. I know that Sue Sauter raised this at the board, and we really do want people to have those discussions very early on about their advanced wishes. And finally, through no fault of the team, the relatives arrived on the ward, and they didn't have the opportunity to inform the relatives that the patient was still on the floor, or to expect to find their patient on the floor. And our patient's daughter fed this back, so we have apologised to her for this, and the team know that they need to explain these things to people in the future. I'll pause there and see if Stephen Dilworth has got anything to add.
Thank you, Jane. No, it was compared to other inquiries, I think relatively straightforward, and I think you've absolutely covered all the points. So nothing else for me to add there.
Thank you. I'm going to have to admit to some difficulties now. I'm trying to stop sharing. Stop sharing. Brilliant. There's a new button I wasn't used to on WebEx. So I'll move on to our next presentation then. No, that's the same one, isn't it? Please bear with me. I may have to call for assistance from Joe here because it's not letting me open the other presentation. It's open on my computer, but it won't share.
Jane, can you email it to me? I haven't got that presentation.
I'll try one more time. Let me just see.
I think we have this frequently in Teams, Jane, where you can present one thing, but it won't ever let you move to a different presentation unless you leave the call and come back in again. So,
really?
If you want to start talking
I might be all right. Hang on. I think I've closed the other. Yes. Oh, thank you. Thank you for bearing with me as I melted in shame there. So Linda Longhurst is going to support me with this presentation. At the last Council of Governors, there was a question and a request to look at themes and actions arising from serious incidents. So we went away and thought we'd look at a period of time between January and June, because this will have given some additional time for the actions to have been taken and the learning to have been embedded more. So just as a reminder, the purpose of the serious investigations is not to apportion blame, it's to take a systemic approach at looking if there's any systems or processes that may be improved, that may have contributed or led to the incident. And the action plan really does need to address any of these systems or processes and look for improvements. So having looked at our incidents during this 6-month time period, I think it's safe to say, and it will be no surprise, that virtually all of the recommendations and actions fell under 3 themes. This is the recording of risk and risk assessment, care planning, and contacts with service users and patients. And this is why they remain our priorities in terms of quality in our quality accounts again this year. And these are really complex issues. And I must say that it's not that they are missing in the progress notes, and it's not that the clinicians are not aware of them and not carrying them out. but often the investigations find they're not in the right place, or the quality of them could be improved. So I've just got some examples of what some of the recommendations under each of these headings are, and some of the actions that have been taken. So the first area is around risk assessment. So some of the recommendations here were about clear recording of risk on the risk assessment form in the Rio clinical record. So risks may have been documented really clearly in the progress notes or in the ward round multidisciplinary team templates, but they actually weren't in the one place on the risk assessment form. Clear and thorough recording, particularly around, this is section 117 care after somebody's been discharged, highlighting service user involvement. Risk assessments being reviewed as a minimum 6 monthly and as required when risk is identified. And the level of risk recorded in the risk assessment must be informed by the most recent patient presentation. So they're all very much a variety of the same message, which is that risks need to be assessed and updated and recorded on the clinical record in the right place at the right time, and should anything change. So the actions that have been taken, most of these incidents have occurred in the community mental health teams. And over the last 18 months, 2 years, there has been considerable work done around induction processes and supervision and leadership, and they've had their own improvement group overseeing this. There's been a clinical lead who's been in place, Catherine Seaborn, and Ian chairs a community mental health forum with Christine. So what they've been doing in those 6 months is developing an even more robust induction process, particularly looking at the role of the care coordinator and training that will support this. This is being piloted, and the actual training programme will begin in January. Local audits are being undertaken, and we continue to encourage team members in the community to undertake DICES training. This is training around risk assessments, which will enable them to really clearly describe risks, identify all the possible options, choose the preferred options, explain their choice, and share the decision with others. So this really improves their assessment and documentation around risk. The next area was care planning. And again, this very much links to risk assessments, because what we want to see is the risk assessments translated into the appropriate care and treatment plan. So some of the examples that came out of the incidents were a falls assessment wasn't completed, there was no falls care plan done then. Patients must have comprehensive care plans, included crisis plans when admitted. Care plans need to be current and recorded in the appropriate section of the RIA records, and care plans should be contemporaneous and completed with the patient to ensure they're individualised. So again, these are being addressed through the overall care plan improvement. In the intermediate care teams, the falls care plans are now added to the care plans, and this is regularly checked by the physiotherapist and the nurse in charge who complete an audit. As I've discussed, the community mental health teams are further developing their induction, and they're auditing the personalisation of care plans. So whilst we have a trust-wide audit that teams look at 5 care plans a month, what they're actually looking at here is, and it's in order to carry out a really good audit, you really need to know the patient and you really need to know the treatment plan in order to be able to tell if the care plans have been personalised. And there's a review of the care plans during supervision. So the final theme that came up is the contacts with service users and patients, and some of the recommendations were about being proactive in making contacts where people have missed appointments, developing a post-discharge assessment protocol, and contacting patients on a frequent basis if they've been discharged from an inpatient setting. I'm just going to speak to Linda, because we know that local audits are taking place and protocols are being developed, but the closure date for this action for some of these was still prolonged. So I'm just going to ask Linda if she has any information to add to this slide for us.
Yes, hello there, everyone. Yes, I do have a bit of an update. There is still more to come, but I have sort of a fair bit. So in terms of contacts, so there's a team dashboard that's been developed, and what that shows is it details the total contacts per team, as well as those service users who have not had a contact within the last month. And then that dashboard also forms part of discussions within team meetings, and that commenced in August of this year. In terms of the local audits, just a bit of a snapshot. So the service line manager monitors the quality and nature of the contacts via, random sampling of records, and then has those case discussions within supervision. And this is also included on the clinician's task list within IFOC, so it's there as a prompt as well. Care coordinators, and I know they were mentioned particularly in the previous slides, they use the Rio diary, and then they make sure that they outcome the appointments on Rio, so that you can run reports to check whether service users have had their weekly visits, so you know that they're taking place. And that is a standing item agenda at the quality meetings. And the protocol is still in the course of being developed, but the post-discharge assessments are carried out in person, and they're more comprehensive now. So these assessments are no longer the responsibility of just one member of the team, but they're shared amongst the team. And so after the post-discharge assessment has been completed, there's a team discussion about the information in that assessment, and then they'll agree the plan. And they've also developed a template for staff to use just to make sure that there's consistency, and it acts as a prompt so that staff know what questions to ask. So that's sort of where we're up to with that one at the moment. Back to you, Jane.
Thank you, Linda. So I think our ongoing learning is that when we're looking at the themes and actions that are coming out of the incidents, is we shouldn't be looking at them in isolation. So if we're looking at risk assessments and involving families, carers, and seeking information back from patients and their families and carers, and getting a really accurate care plan, we have to have teams looking at all of these things collectively together. And this is where the community mental health teams particularly have been focusing on over the last few years, and we as an organisation continue to champion this through the quality accounts. So I think just to remind people in summary that the patient safety aims to reduce risks, errors and harms, and we take the lessons learned to try to prevent future harms from other. And the action plans are a key document that help us monitor this for improvement. Thank you, and thank you, Linda, for the updates on the care planning. I'll stop there and see if I can.
Thank you, Jane. Thank you, Linda. Any questions on that item from anyone at all?
Yes, hi Steve, it's Cassandra from Bridge again, if I may ask a couple of questions.
Yes, please go ahead, Cassandra.
So we work extensively alongside the community mental health teams, and I welcome all that we've been involved with some of the changes and improvements that Jane's highlighted. A couple of things. I see the diocese is about sharing with others what is being found. It'd be really good to know that that includes any support workers that are involved with working with the clients, with the patients, so whether they're in supported accommodation or whether they're receiving support in the community. And I also note there's stuff around making contacts, your contacts dashboard. I wonder, does that include what kind of contact that is? Because we know that contact can be a text message, a phone call, or a face-to-face contact. And I think too often we have felt that there's a heavy emphasis on maybe a text or a phone call and not enough face-to-face. Certainly not enough face-to-face with a sort of pre-arranged appointment. So anything that we as provided supported accommodation and community support can do to help make sure that our clients make those meetings. So often we get quite a lot of people just dropping in and then they I don't know whether that counts as a contact they've tried, but they haven't made contact, where we get to in that. And then I think I think the root cause, which may not be in here, is that the caseloads of the community mental health teams, particularly in ICMP, is just unsustainable. We see that. We see how much better the early intervention teams and the comrades teams are able to work with their clients because they have a lower caseload. And we've had another recent incident, which I'm sure Jane's probably aware of, in the last month or so with one of our clients. And so it just feels that we really appreciate the induction process. We understand that is going to help. But I do think that I've had raised this with Ian before, there's a real need in terms of making sure that we've got sensible caseloads that people can manage. We can put all the monitoring in place, but if they actually can't get out to see people, that won't help.
Cassie, I think you've made some really important points. Some of the audits that I've been privy to about face-to-face contacts, particularly around CPA, do show that they have been face-to-face as opposed to virtual. But I'm absolutely certain some of the contacts, although they may be recorded as attempted contacts, they haven't been achieved. So I'm sure there's more work that we can do on that. I don't know whether Ian is able to comment on the caseload sizes, because I know that this is something that's been looked at through the Community Mental Health Forum. And there's also been some developments across the South London Partnership in terms of a workforce development for these teams and building competencies and different roles, but it doesn't take away from the fact that we do have very large caseload sizes, and this is a problem that is fairly common to many trusts in terms of their community mental health caseloads. And I don't know whether Ian is able to update further on anything we can do to reduce these.
I think it's gone to another meeting, but I fully empathise with where you guys are, because I think it is really tough. But we do see this as a fundamental kind of change that needs to happen. So I know it's not something that can happen overnight. And just to add to that, there's the real understanding that care coordination is a real skill. It's about having time to build relationships. It isn't just about tick boxing. Tick, I've made contact with that person. Tick, tick, tick. It is about having the skills and the time to be able to invest in the relationships. And I think that's what we see where we work relatively successfully, we like to think. You can shoot me down if you think not, but it's the ability to build the relationships, and that's what's so frustrating. The feel that care coordinators could be so much better at their roles if they were able to do that.
Yeah.
So can I just come in? It's Ife here, just to say that these are some of the things that are being worked through at the Mental Health Community Care Forum. We recognize caseloads are high, certainly not what we would desire, but we've got some sickness, we've got some vacancies, and those things push up caseloads. And you're absolutely right about the role of the care coordinator, hence the things that you did jointly with Catherine and colleagues to ensure that people who come in as care coordinators get the right induction, the right things and are put through to understand what their responsibility will be. So we are working on this. We're also looking at caseload weighting in terms of it's not just that I've got 30 or 20, it's about the complexity of those cases. And that's certainly something that we're paying a lot of attention to, and we hope that over the next 3 months or so, we'll come to a definite position. I had a meeting this morning with the associate directors, and it's one of the things we talked about, starting particularly in Greenwich. So it's a real focus for us, without any doubt. And your comments about contact, of course, you're absolutely right. It's not just about popping in, it's also about meaningful contact. And ideally, we want to take on board the contact by people perhaps from your team and other teams that are supporting the patient. And lastly, can I just emphasize that this is the real value of having our CPA meetings, that it gives an opportunity for everyone involved in the individual's care to come together to talk about what the issues are, what their contributions are, and also to ask the individual, what they found helpful and how all of that input has helped them going forward. Thank you.
Thank you, Ife. You had a question, Sally, on behalf of Ray.
Yes, Ray asked whether risk assessments of people cover whether they have behaviours that lead to restraint. And if there are assessments, will that help to create plans so that they can be supported to have other than supine or prone restraint used with them?
I come into that if possible. So quite a number of the point about restraint applies largely, but not exclusively, but largely to our bedded services. And quite a number of our teams, right from our forensic services, have a tool that they use commonly called the Brosette tool that we require or we encourage our staff to complete 3 times a day, that just looks at a number of items that predict who might become aggressive or violent, etc. And if this is used properly, then it's possible to preempt what might happen and to then have a conversation with individuals. So that's the first thing. And then the other thing we encourage people to do, which speaks to your point, is if the risk assessment does indicate, Brosette tool is also a risk assessment tool. If it does indicate that someone has a past history of being aggressive or indeed has required restraint, we ask that a discussion is had with that individual to just talk through how we might help them if they got into that position. But of course, what we try and do is to try and preempt or prevent that from happening in the first place. And it's got to be a multidisciplinary team approach, because what we find is that where you've got enough activities going on in the ward, where the staff understand the issues for the individual and are constantly talking to that individual, then the chances of requiring a restraint are less. But as you know, reduction in restraints in total, fiscal restraints in particular, is one of those priorities for us as an organization. So we're constantly working on this.
Thank you, that's very helpful. Thank you. Obviously, generated great deal of interest there. There's comments on the sidebars that people can see as well. And quite rightly, we're going to come back to this in about 6 months' time to have another look at this. Thanks very much for that contribution. If we go on, please, to item 10, you'll notice that we've been really interested in lots and lots of topics. So time is marching on. So without wishing to miss any of the quality of what you're going to say, if brevity would be, I'd be obliged for as well, please. Thank you very much. Who's presenting on item 10?
That would be me, Andy, myself and Iffy. So very briefly from me, the quality reports is a statutory annual requirement from NHSEI. It was reviewed at PQAC in October. It was signed off by the board in November. And the purpose for us bringing this item here is that it's customary for governors to choose a quality indicator that will be audited by the auditors. And if I could hand over to Iffy to talk us through those indicator options available and provide highlights. Thank you.
You're on mute, Iffy.
Yeah, I'm so sorry. So you didn't hear any of what I was saying. So I'll just say thank you, Yemisi, for that. And just in the interest of brevity, Joe, can I ask you to move us to the second to the last slide, please? So as Yemisi has said, essentially what we want the governors to do, if you keep moving, second to the last slide, please. The main reason for this is to get governors to pick an indicator that will be subjected to audit by our external auditors. Next slide, please. And here we have 4 options that we want you to consider. Now, there are a number of reasons why we've put up these options. The first is that external auditors, like accountants, need to be able to count whatever indicator we choose. And so it's something that they need to do from the back end of RIO being our electronic patient records. If we give them anything that's qualitative, that wouldn't work. And we had this problem a few years ago. And so we've identified out of our quality priorities 4 options that they can count, and then go into the detail about assuring the board and of course yourselves and the public at large that our systems are sufficiently robust to capture this, and therefore the data we provide is good quality data. So you can see the options in front of you. Can I also say that last year, option 3 was chosen for audit this year, but as a result of COVID, the NHSEI decided that we wouldn't subject the quality accounts to audit. So one option might be to bring forward option 3 again for audit this year for next year's account. So the first is about identifying support network. You see we've got 2 thresholds, one for mental health and forensic, which is 80%, and then 50% for physical health or community health services. Option 3 is about making sure that 95% of people we see have a recorded care plan in our electronic record reel. And then option 4 is to do with restraints, which was a subject, which was a question that I just addressed moments ago. But this is more about making sure that following any use of medication, in addition to restraint, that we check people's physical health, their pulse, their blood pressure, their temperature, etc. So those are the 4 options. I was checking with Sally about how we might do this, and I wonder whether the best thing to do would be to consider these options, and then you'll get an email from Joe or Anne-Marie to respond to, and then we'll total up the one that's got the highest number, and that's what we'll recommend to the auditors. Thank you. Andy, that's us done, and I hope that was brief enough. Happy to take questions.
Yeah, okay, thank you, Ife. I take it we'd do these things anyway. This is really a matter of the external audit. That's the question?
Exactly, yes. This is just about external auditors picking one to just thread the line through to make sure that whatever we report is actually comprehensive, accurate, yes.
So the action is for them to have the option to choose from those 4 options. Is that correct? Yeah. Okay. Any questions on that at all? If not, thank you very much. Is there anything else on that at all, Ife?
No, there's nothing else on that.
Okay. Thanks very much indeed. If we go on to the next item, which is holding NEDs to account, which includes the my appraisal. So if at this stage, what I would normally do on a face-to-face is leave the room, but I will now leave the room at home and take with my phone, and when I am telephoned or texted by whoever so it is, I shall return. Now, Sally has just told me that there's a question from Leslie just before we move on to that next item. So just let's deal with this firstly. Leslie, please.
Hi, thank you. It was it was going back to when he was talking about the restraint. I was at a conference on Monday about trauma-informed care, and they were saying about the use of restraints can reinforce trauma and bring it back. And I was wondering, I didn't know how much trauma-informed care the Oxleas use, and I wondered if you could let us know a bit about that.
Ify, you're muted.
Sorry. The brief answer is yes, we do use trauma-informed care, and we do in our inpatient area. It's not used right across all the units, but a fair number, a higher proportion of our inpatient wards do use it. And one of the things we then want to do is to cascade and share right across the rest of the wards. I chair the acute care forum, and it's one of the things that we receive feedback on. And if it helps, Leslie, we can have a conversation and invite you to one of those meetings to be part of it. But it is something that our clinicians are definitely using.
Thank you. Yeah, you will have noticed there's another item on the agenda about quality management. Amlan, I've had a message from another colleague. So can we put this back to the next meeting, or do you want to do this one now?
To be honest, my view, I don't know about Vicky, would be that it does require a bit of time actually. So I would have no problem putting this to the next meeting.
Okay, I'm grateful for that. So we'll go on to the holding next to account at this stage. Then I shall remove myself from the, and then I'll await a call back. Thank you.
Okay, colleagues, I think I'm starting on this item. Can everybody hear me okay? Two items here. The first one, hopefully we'll go through, go through it all fairly quickly, is governor activity at the board and at board committees. All I would add to what you've got in front of you is, in addition to what's listed here, the chairman very kindly invites me to sit in on informal meetings of the board. In the normal circumstances, they tended to be bi-monthly. We've actually gone now to a system of meeting every Tuesday lunchtime, just for a quick update from Matthew. And that's a very useful way of sort of keeping in touch with what's going on. In terms of the committees themselves, just remind colleagues that Anne-Marie sent round an email, I think on about Monday, Tuesday of last week, with a schedule of when the various committees are to be held in the first 6 months of next year, and hope that colleagues will find time to be able to sit in on those. I think it's a really important way of both holding the non-executives to account and also for making sure as governors we really understand what's going on in the trust. Obviously, if there's any colleagues who wish to make any particular comments about meetings they've attended or any questions, happy to take those now. I'm just trying to see, maybe Sally could shout at me and say if anybody is asking any questions at that point before we move on to the second half of this item. I'll take silence as people are happy. The other item on the agenda here is the chair's appraisal. As we discussed at our meeting in September, we've had to adopt a slightly different process this year because of instructions from NHSEI. Steve James has taken us through this process, led it as the Senior Independent Director. And at this point, I'm going to hand over to Steve to explain what's happened and what the conclusions are. Over to you, Steve.
Thank you, Richard. Good afternoon. I'll be really quick because I think most of the content is in the item in the papers. Chairs of NHS trusts need to have an annual appraisal. That's normally undertaken by the Senior Independent Director. It's become a tighter process, and NHSIE require the appraisal to look at a number of areas which are listed in the paper. So strategy, partnership, people, professional acumen, and focus on outcomes. After talking to Richard, we decided that we would send an email to all the governors, and I'd like to thank everybody who replied, giving me their views on that. I also spoke to partners, executives and NEDs, and particularly people from outside the trust to get a view about how they thought Andy performed. You can see from the report that there was universally positive comments about Andy, which I don't suppose will come as a surprise to anybody who comes across him. And that's particularly impressive in a time when COVID has led to really complicated issues around how you communicate with people and governance issues, and a number of people commented on that. I'm happy to take comments on it, but the report is relatively self-explanatory. Looking towards the future, a number of people said that they would really like Andy and Oxleas to take an even more prominent role in partnerships, which we've talked about already, and that Oxleas can play a leadership role in South East London, which I think we would all want to happen. So I'm very happy to answer any questions people may have. But again, I'd like to thank everybody who gave me their time to help me undertake the process.
Anybody want to chip in at this stage and say anything?
Just to say, from my perspective, Andy's been fantastic to work with. You know, appropriate support, challenge, and great insight, Richard. And thanks to him and all the board, actually, and also thanks to Steve for pulling this together, appraiser-wise. But I mean, I couldn't ask for a better chair. He doesn't give us an easy ride sometimes, but you know, when we're on the rough end of it, it's for the right reasons as well. So he's brilliant to work with.
Is there anybody else who wants to come in before we ask Sally to let Andy know he can come back in the meeting, and we'll tell him that would like him to carry on?
We could drag it out a bit just to make him, you know, say that there was a lot of discussion.
Can I just say something?
Please do, Sue.
Hi.
Sue, is it? Yes, I thought it was.
Yeah, sorry. Just to say that having been with Oxleas Trust for 2 years, and it was a completely new role for me, having even worked in the NHS previously in various roles, but he was, like all the non-execs and the executives, have been very supportive. And Andy certainly helped me feel more confident when attending some of the roles, when we could meet it properly and virtually. And I think that goes for everyone. But yes, I would support him all the way, and hope the new governors find him as supportive as I have. So thank you.
Yeah, well, certainly, you know, my impression from a personal point of view is we're extremely lucky to have him. And when I talk to governors from other trusts of some of the tensions there are between them and their chairman, I think it's, you know, we are suitably critical friends, but at the same time we get on extremely well as a group. So if that's all people have got, Sally, could you ask Andy to rejoin us? A few moments while we silence for what we actually do at this.
He's obviously got a big house.
Yeah.
Maybe he's decided not to come back after all.
Yeah, real chance to escape.
That would be quite something, wouldn't it? You just walk out and never saw him again.
Yes.
Yeah, I did come back, Steve.
Oh, right. Well, yeah.
Well, we had our discussion, Andy, and would like it to stay.
Yeah.
Was that a fairly balanced decision?
It was touch and go, to be honest, but you know, in the end, the balance.
But I think
let's give me the name, Steve.
Andy, if I may, for a second, just at the appropriate time, because I know you know you're always quite rightly very fulsome in what you say to the staff and what your colleagues do, but there aren't many opportunities for us to say thank you very much to you for all you do, the commitment you've made, and the leadership you provide for the trust. It is very much appreciated by the governors, and we're looking forward to working with you as time moves on.
Yeah.
Well, I'm very grateful. Thanks very much. So I'm presuming you want me to stay, and thank you very much. If that's the case, we'll move on to the next item, which is constitutional changes. And Sally, please.
Thank you. So this is bringing back to the Council of Governors the changes that we suggested in the September meeting. So just after the September meeting, there was just a query raised about the third proposal, where one of the governors hadn't been able to share comments at the time. So we've taken that feedback on board and just revised the text slightly just to broaden out some of the concepts there. And have taken that to the Board of Directors. So all the proposed changes have been agreed by the Board of Directors, as well as the two that were done by the Council of Governors. So in your pack, you've got an updated constitution showing the 2 changes that have already been agreed. But what I'm asking you today is to confirm whether you agree with the revised text for the advertising requirements, and if so, we will enact that change for you.
Sally, I may have missed that. Is it worth us explaining what the difference is?
Just saying that it's rather confirming that we will use a range of ways of, as well as social media, a range of ways of telling the community about our meetings, such as local libraries, posters, that type of thing. So it's just broadening the range of ways that we are looking to tell people about our meetings, and taking out that it will purely be through the local media.
Right, thank you. Because Leslie, I think last time you wanted too narrow as far as how we notify people of our meetings, and wanted it not to exclude the more traditional ways of local papers, etc. Clearly, there's a cost associated with that. But this is about using a range of means by which we can advertise. Leslie, are you content with that amendment?
Yeah, I am. My concern was that a lot of older people don't use social media, so it was excluding them. And this is great. I'm happy with that.
Good, thank you. Thanks for that intervention. Are we all happy with this change? I mean, it's hard to have a vote online, but people to sort of signal if they are unhappy. I shall take no comment as we are happy. So if we're all content, then that is agreed. Right, so we go through to the membership committee update. Is that Rebecca, please?
You're on mute, Rebecca, I think.
Is that better? Can you hear me now?
We can, thank you.
Yes, thank you.
Okay. Right, okay. I do work at Eltham Community Hospital, so I apologise for the PPE that we are expected to wear, but as was mentioned earlier, we are part of the COVID pathway, so we have to be really careful about how we do, and I sit in the patient's lounge to have these meetings, so that's why you cannot see half of my face, so my apologies. But we've had membership committee meetings on the 5th of October and the 27th of November, and we have looked at building services and carers interest groups for the membership. So one group is focusing on increasing the number of young members, and the other group is talking about, we talk about increasing the membership base within the forensic and the prison settings. So they are sort of work in progress. We also have talked about the annual members meeting, which of course, like everything this year, is online, and we discussed the differences in the way that the people engaged, because the number of people engaging was much higher. So we had over 400 people engaging in that annual members meeting, compared to around about 100 last year that was physical, and it was at the Charlton Football Club. And 91 of those were live, and so they attended at the meeting, and then 323 of them followed up afterwards. We didn't know, we looked at whether, we talked about whether people stayed for the whole meeting or whether they just stayed within parts of it, but of course that's quite difficult to get information on. And then we had a chat about how the virtual communication is going, because although it might seem like old hat to us now, we're still really aware that some people are still getting to grips with it, and you know, how we can maintain good communication links with our members going forward. And we're looking at holding the online governors review this year, which some of our governors have put forward their names to be taking part of that. And we're looking at social media and other opportunities to be able to reach out to people where normally we would be meeting and greeting, but we can't do that this year. So thank you very much.
Thanks, Rebecca. I think Andy has frozen, from what I'm being told.
Okay, what was left on the agenda?
So the next item is from me, and it's for information only. It's just showing how the governors have been involved in activities since the last Council of Governors.
Okay. I don't know who technically should chair in Andy's absence.
It would still work if he's still on the call.
Yeah.
How's that? Can you hear me now?
Yes.
Yeah, cut out the video. Right, thanks, Rebecca. Joe, anything to add to the governor's activity report?
No, nothing further, Andy.
No, okay. Well, that's very much, you know, thank you, Joe, and to Anne-Marie for all the support you give to the Council of Governors as well, because I think, you know, sort of whirring away in the background all the time and doing an awful lot of work. So thanks very much indeed for everything you do on that. Any questions on governor activity at all? If not, we're going to any other business. Rebecca, I think you have an item for any other business, don't you?
Unmute. Can you hear me?
Yeah, I can hear you, Rebecca.
Okay, thank you for that. Within I'm doing a part-time, just to let you all know, I'm doing a part-time postgraduate degree with Kingston University in leadership and management for health. And part of that we're doing is looking at a piece of work which involves evaluating and to be written up as a dissertation project. So, having thought long and hard, I really enjoy the governor's role. It's part of what we do, and I have proposed that to do a service evaluation. It has, and it's about to ask all the governors, and that doesn't mean to say everyone's got to participate. There's very much a choice thing, and it's going to be an online questionnaire about their leadership skills. So without going into too much detail, there is an NHS leadership module, a model which was formed in 2013 by the NHS, and it looks at different areas, so like inspiring a shared purpose, holding people to account or systems to account, which is what we do, developing capability. There's 9 different areas, and I was interested to see whether, as governors, we are able, whether we use any of those skills. So it's very much about whether people feel they use those skills or not. So this is, it's gone through the ethics with Oxleas, as all evaluations need to do, and that's been approved. And it's gone through the ethics for Kingston University, which has also been approved. And I have a very good support tutor, and his contact details will be on the email that goes out. I want to emphasize there is absolutely no no enforcement, no, it's very much a choice thing whether you want to participate or not. So everyone by mid-December, so by the 14th of December, everyone should have got an email, all the governors, to ask them whether they want to participate. It will have the details of the study, how they will remain anonymous, how the data is collected and maintained for safety and confidentiality, and how the work will be produced and published.
Thanks, Rebecca. So that, okay, Rebecca, thanks very much indeed for that. So that'll be sent out then.
Yes.
To colleagues. Yeah.
Thank you.
Okay. Well, best of luck with all that. Best of luck with all that, Rebecca.
Thank you.
Anything else from anybody else under? Thank you. Under any other business? If not, there was a question on my appraisal from Ray about growth and development. I've just passed my appraisal to my wife and said there's a lot of areas for improvement apparently. So she gives you a lot of direct feedback. But no, I think seriously, I think the around the ICS, the South East London, around SL, the partnership with Lewisham and Greenwich. Personally, I see those are the areas where I'm going to put a lot more focus on in the next 12 months. Some of that's imposed. I don't want to lose focus on things within Oxleas, but there's so much happening in the external world that personally I feel I've got to step up into that area, and I'm reporting back in due course. In the absence of any other business, I'll draw the meeting to a close. Thank you all to fellow governors for today. Thank you for all your work during the year. I really look forward to seeing you all in person. I hope we can next year as soon as as best we can. A huge thanks to all the staff at Oxleas for everything that you've been doing, and I wish you all the best Christmas that we can have under the circumstances. So I'm very grateful to you all. Thanks very much indeed, and goodbye. Thank you.
Bye, everyone.